It's wonderful to see those who are here in person, and I know we have lots of people participating remotely as well. So my name is Dr. Krista Tsela, and I am the Senior Associate Dean for Medical Education. On behalf of the Larner College of Medicine, I would like to welcome both our in-person attendees and our online attendees to our 10th annual Health Equity Lecture, which is held as part of our celebration of the life and legacy of the Reverend Dr. Martin Luther King Jr. Although Dean Page is unable to attend this important event this evening, he has asked that I send his regards. Across the UVM campus this week and into next, Dr. King is being remembered for his accomplishments and the enduring promise of his work. Here at the Larner College of Medicine, we take note of Dr. King's statement that he made in 1966 to the Medical Committee for Human Rights. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. There is much work that still needs to be done to protect his legacy and achieve his vision for our society. The Reverend Dr. Martin Luther King Jr. Celebration and Learning Series was established a decade ago to explore matters of health equity within our systems of healthcare. To further our commitment to health equity, we welcome Dr. Quinn Capers this evening to engage our community in a conversation about how diversity in medicine will save lives. Dr. Capers is a professor and inaugural vice chair for diversity and inclusion in the Department of Internal Medicine at the University of Texas Southwestern Medical Center and a member of its Division of Cardiology. He holds the Roddy P. Cox MD Professorship in Internal Medicine and serves as his university's Associate Dean for Faculty Diversity. He is nationally known for his work on implicit bias limitation. I would like to thank our Office of Diversity, Equity, and Inclusion for organizing this and other recent events, and especially Tiffany Delaney, Director of the Diversity, Equity, and Inclusion Office, and Dr. Margaret Tando, Associate Dean for Diversity, Equity, and Inclusion, for their efforts to develop and support DEI initiatives in our Larner College of Medicine community. And now I would like to introduce Dr. Ann Doherty, Associate Professor of Obstetrics, Gynecology, and Reproductive Sciences, and the Director for Gender Equity in our Larner College of Medicine Diversity, Equity, and Inclusion Office.
Thank you so much, Dean Zela, and thank you all for coming, and thank you all who are in Zoom land for being with us for this really important lecture. My name is Ann Doherty, and on behalf of Dr. Margaret Tando, our Associate Dean for Diversity, Equity, and Inclusion of the Larner College of Medicine, it's my privilege to welcome you to the 10th annual Reverend Martin Luther King Jr. Health Equity Lecture. The Martin Luther King Health Equity Lecture was created, as Dr. Zela mentioned, in 2014 as a way to inspire our community to engage in campus dialogue and community engagement and civic education around the topics of race and racism and their relationship to the vast health disparities that we see in our society. And thanks to the generous support of the Dean of the Larner College of Medicine and Larner alumni, the lecture has grown tremendously over the last decade. And we're pleased that members of both our university and our local community join with us in learning together. Each year, we seek speakers that include scholars and thought leaders whose perspective and viewpoints enhance our understanding and appreciation of inclusive excellence. And the words that Dr. Zela quoted from Dr. Martin Luther King around the shocking and inhumane nature of health disparities, we hold them as true today and recognize that we have work to do in this field. As we celebrate the life and work of Dr. King, we can also reflect on how his commitment to ending injustice can apply to the work of eliminating health disparities in populations around the world. And I'd now like to bring to the podium Dr. Layla Amiri, our Associate Dean for Admissions at the Larner College of Medicine, to introduce our keynote speaker.
Thank you so much, Dr. Doherty. Good evening, everyone. And we're going to have fun because I have a lot of introductory comments for you. So I invite you on a journey with me to hear a little bit more about Dr. Capers. It's really an honor, a pleasure, a distinct honor for me to be here and have this privilege to introduce Dr. Capers as our speaker tonight. Dr. Capers, as you've heard, is an interventional cardiologist, professor of medicine, and transformational leader in academic medicine. He's been widely decorated as an educator, clinician, and champion of diversity enhancement in medicine. He introduced the transradial artery technique of coronary stenting to the Ohio State University cardiac catheterization laboratory and led its transformation to a radial first lab. Physician peers have named him one of America's best doctors annually from 2009 to 2020. And his patient satisfaction scores placed in the 90th percentile nationally for 6 of the last 7 years. In 2019, he was elected into the OSU Society of Master Clinicians. From 2009 to 2019, he served as the Associate Dean for Admissions at OSU and led the admissions team to achieve several high marks in racial and gender diversity. During his tenure, the average MCAT score of the entering class remained at or above the 90th percentile. In 2017, the U.S. News and World Report listed OSU number 2 of 152 majority race medical schools for the total number of enrolled African Americans. In 2012, Capers had all admissions committee members take the implicit association test to uncover hidden racial, sexuality, and gender biases. And this led to the first study to document the presence and extent of unconscious racial bias in medical school admissions. Capers is widely sought as a speaker and workshop moderator on implicit bias mitigation. To date, he has moderated over 300 implicit bias mitigation workshops, training over 2,000 physicians in strategies to reduce implicit racial bias in patient care and in the selection of medical students, residents, and fellows. He led a dramatic turnaround in the diversity of OSU's cardiology fellowship training program. Prior to his arrival in 2007, the institution had never trained a Black cardiologist. 2007. It is now considered a leader in diversity in cardiology and has received national recognition in this regard. Dr. Capers is considered an international authority on the topic of diversifying undergraduate and graduate medical education training programs. He was elected the inaugural chair of the American College of Cardiology Diversity and Inclusion Committee in 2020. Capers is a graduate of Howard University and the Ohio State University College of Medicine and trained in internal medicine, cardiovascular diseases, and interventional cardiology at Emory University. In 2020, he joined the faculty at the University of Texas Southwestern Medical School, where he serves as the Rhodey P. Cox Professor of Internal Medicine, the Associate Dean for Faculty Diversity, and the inaugural Vice Chair for Diversity, Equity, and Inclusion in the Department of Internal Medicine. So please join me in welcoming Dr. Capers to the podium.
Well, thank you. Thank you so very much, Dr. Amiti. We go back because we share that medical school admissions experience and bond. And boy, it's such a pleasure to see you and interact with you here. Thank you for such a warm introduction. I want to thank all of you for the warm introduction. I've been here having a series of meetings all day. My first time in your great state. And I hope to be back. I did not dress as warmly as I was supposed to. I've lived in Ohio, so my wife told me, "You're going to Vermont, take your parka. You got to take the parka." I forgot to pack the parka, but I'm told it's unseasonably warm today, so thank you for that. I am really honored to be here, to be with you and share a few comments with you. And I entitled my comments, "Why We Can't Wait." And so if we remember Dr. King's very famous, very moving letter from a Birmingham jail, while he was in jail in Birmingham, he laid out kind of an answer to some local clergy who had been criticizing him. And part of their criticism was, why now? Why do you have to cause all this ruckus right now? And as a follow-up to that, in 1963, he wrote this book, Why We Can't Wait. And in that book, Why We Can't Wait, he laid out in a very scholarly fashion the frustration from waiting for justice in all of the social determinants of health and wellness that we talk about so much. And I think I too, just like you in this room, we're tired of waiting. And there's so many reasons not to wait. But we sometimes are told to wait, to go slow. I've been told at times that, yes, it is true that we don't have a very diverse physician workforce, but this place, the faculty or the medical school or the residency, this is not the place to fix it. Go back and fix kindergarten first. We got to fix the injustices in education first. You don't fix it here on the search committee for the neurosurgery chair, or you don't fix it here while we're picking ophthalmology residents. So go back to kindergarten first. So I wanted to frame this with a sense of urgency of why we can't wait. So first thing I want to do, and I know this is bizarre, and you might not trust me, but Layla will tell you you can trust me. So I want you to close your eyes. So please, everybody close your eyes. And I want to paint a picture for you. And I want you to imagine a few things. I want you to imagine a world where doctor-patient communication is uncomfortable, stilted, and leaves both the doctor and the patient a little unsatisfied. Imagine a world where the breakthroughs in biomedical research, and I mean breakthroughs like statins, TAVR, antibiotics, real breakthroughs in research only reach a small audience and therefore have only a portion of their potential impact. Imagine a world where the most vulnerable of our patients, those in rural settings, underserved, urban underserved, those with low socioeconomic status, just don't have enough doctors who are excited about taking care of them. And imagine a world where a patient's race or ancestry influences their treatment plan to the detriments of patients of color. Imagine all of that. And now open your eyes and you see me looking at you saying, hello. That's the world we live in. That's where we are today. Welcome to our world. Welcome to my world. Welcome to your world. I'm going to posit for you that the lack of diversity in medicine is the healthcare crisis of our times, and that medicine, as wonderful a thing as it is, it will never reach its full potential to alleviate suffering and improve lives until it leverages talent from all backgrounds. Now, I am active on Twitter, and we call each other tweeps. When you've got Twitter, a friend from Twitter, so some of my tweeps are in the audience here. And I was talking to somebody earlier today about how social media can be used for good purposes or for evil purposes, but of course we advocate using it for good purposes. But one of the things that you can do on Twitter, which is a good thing to do, is you can set up a poll. So not so long ago, I made a poll on my Twitter page to poll my followers, and I asked this question, and I want you to consider this question also. So please answer and retweet. If a colleague asks me why do we need more diversity in medicine, I would have a strong, evidence-supported answer. And then I have, as you see there, the Likert scale, or close to the Likert scale. Well, as you see there, 75% of 1,000 people voted on that poll said either agree or strongly agree, but a quarter said disagree or strongly disagree. And I want you to think about that. So let's say it's you. You walk into a room and you've got your colleagues there, and you're saying, well, we really need more diversity in medicine. And somebody challenges you. I say, why? And I want you to think about, would you have an answer? Would you be able to debate them with data? Well, here's what some of my tweets said. So Carl is a friend of mine. We went to medical school together, so he doesn't mind me showing his face here. Carl said, I put disagree, because while I agree with the premise, I don't have the data in my field. He's a pulmonary critical care specialist. Another person said, it's a great question. I definitely support it, but it's based in experience with the population I serve, but I lack knowledge of academic evidence to make my argument. Somebody else said, interesting question. I have deeply held personal reasons for favoring diversity, but I wouldn't stand up to a debate. So I want us to think about that. I want you to think about that, and I want you to be prepared for that challenge, to be able to debate, and all thinking about why we can't wait. I want you to feel a sense of urgency. So why do we seek diversity in medicine? So I thought I would put this in the form of a multiple choice question, because I've heard through the grapevine that you all here at the University of Vermont are very good test takers. And so, as you know, the best way to approach a multiple choice question is to begin by crossing out the responses that you know are incorrect. And usually you can get it down to 2 then you got to use your noggin to pick the answer. So this is a single best answer, multiple choice question. The question is, why do we seek diversity in medicine? And I'm going to expect you to come up with the answer by the end of this talk. Here are the choices, and your job is to cross out the incorrect responses until you're left with the correct one. So why do we seek diversity in medicine? Is it because A, physicians who train in diverse environments rate themselves as more comfortable treating minority patients? Or is it B, underrepresented minority physicians are more likely to serve the underserved? C, maybe because minority patients are more likely to follow the recommendations of minority physicians. Maybe it's D, diversity in medicine will help us reduce racial healthcare disparities. Or maybe it's E, diversity on research teams enhances the impact of the research. So you're going to cross out the incorrect responses until you're left with the correct answer. But let me give you some background first. This is a paper by Saha and colleagues published in 2008, in which they did a survey of graduating medical students. And they asked those graduating medical students about their comfort level treating patients that are in a group different than your own group, a different religion, a different race, a different demographic. And what they did is they went back and they looked at the compositional diversity of the student body where they attended medical school, and they saw a relationship. They saw that the more diverse a milieu you trained in, the more comfortable you were treating patients who come from a group different than you do. In the comment, it says, in this cohort of more than 20,000 graduating medical students, white students, because that's really what they wanted to find out about, white students who attended more racially diverse schools rated themselves as better prepared for dealing with minority patients and treating those minority patients. I've got more data for you from the Double AMC. This is looking at, and I had a good time chatting with your students today, and I reminded your students of something that if you're a physician, you may or may not remember this, but for more than 20 years, the Double AMC has been working with Double AMC member medical schools to ask a question of first year medical students and graduating medical students in their last year. And that question is, do you plan to practice in an underserved area? So in this analysis of 80,000 medical students asked that question, do you plan to locate your practice in an underserved area? Here's what they found, and they compared the answer first week of medical school to those students' answers the last week of medical school. First of all, they found that the Black and Hispanic students were more likely to answer yes than were the white and Asian students. And there were a group of students that were undecided. So the options were yes, no, undecided. Black and Hispanic students that were initially undecided were more likely to answer yes by graduation. White and Asian students that were initially undecided were more likely to answer no by graduation. Isn't that interesting? So you think of the grind of medical school. There's something that happened in those 4 years, that grind of medical school, that had the undecided Black and Hispanic students by graduation saying, yes, I think I would like to practice in an underserved area. Likewise, there's something that happened in those 4 years of medical school that had the white and Asian students who were initially undecided saying, no, I don't think I will practice in an underserved area. I think that has implications for our curriculum and how we think about that. But I wanted to start with this because this is at the very beginning of medical school. This will be important. We'll come back to this. So that's entering medical school. What about after they finish their residency and their fellowship? I had a goal for this slide. The goal was to put on one slide every study that has ever shown that Black, Hispanic, and Native American physicians are more likely than physicians in other groups to locate their practice in underserved communities. But I failed because the slide wasn't big enough. So you'll have to settle for 10 studies in 4 different decades that all remarkably show the same thing. So I want you to understand medical students come in with that desire, and they're not just talking, because they graduate, they do their residency, and then they actually go out and practice in those underserved communities. I want to give you more background data because I want you to do well on this test. What you're looking at here, pictures from yet another study done by Saha. I'm a big fan of his, where they used not standardized patients. We all know what those are. Those are actors playing the role of patients. They use standardized doctors. These are actors playing the role of doctors. And you see there, these doctors, you see men, women, blacks, and whites. And all of these doctors did a video clip, these actors, and they read an identical script. And the script said this, by the way, they were pretending to be cardiologists, something I can relate to. So they said, I've reviewed your tests and I recommend that you have open heart surgery. Now they gathered up actual patients, so actual heart patients, to view the videos. Each patient only saw one video. They then asked those patients some questions, and they asked them, among the questions was, well, what do you think? Are you going to have the open heart surgery? And results show that the Black patients were more likely to have the open heart surgery if recommended by the Black physician. There was another study that came out of Oakland, which was not a simulation, but they randomized Black male patients to having their preventive care clinic performed by a Black physician, a white physician, or an Asian physician, who all recommended to those patients that they get a flu vaccination, a glucose test by finger stick, and a cholesterol check by finger stick. And they were more likely to have those, the Black men, if they were recommended by a Black doctor. So that means if you're counting, that means if we had more Black doctors, more minority patients would have open heart surgery when indicated. More minority patients would get a vaccination when indicated. And more minority patients would get their cholesterol checked and their glucose checked when indicated. What I want to do now is go on rounds. So let's go on rounds together. I'm a cardiologist, so you're coming with me. The first patient that we're going to see is in the CCU. It's a patient with severe congestive heart failure, ejection fraction less than 35%, which means a very weak heart, and refractory to medications. Now, we know that patients in that category are at risk for cardiac arrest. I know there's been a lot in the news about cardiac arrest rate recently, but they're at risk if your heart is very weak and you're having suggestive heart failure and refractory to medicines. Sometimes the heart just says, I quit, just stop. So what we know is that those patients benefit from having an implantable defibrillator, a little computer put in the chest that will monitor the heart rate, and if it stops, shock it back to working again. So you and I are going on rounds. We've got two patients here that are at risk for sudden cardiac death. They both have congestive heart failure, refractory to medications. My question to you is, who gets the AICD? And I think I can read your mind. You're saying, of course, both. What kind of question is that? Current data shows that the white male will be more likely to get the defibrillator in today's US healthcare market than the Black woman. Let's continue our rounds and go down to the ED, the emergency room, where there are two patients having a heart attack. What we know in my field, interventional cardiology, is that time is muscle, as we say. And that means when somebody is having a heart attack and that coronary artery is occluded, the faster we get them to the cath lab, do the heart cath, find the blockage, open the blockage, the more heart muscle we salvage, and the better they will do. The more likely they are to survive that heart attack or survive that heart attack with intact heart muscle function. Who gets timely cardiac intervention? You and I are seeing both of these patients, and I can read your mind, and I bet you're saying, why, of course, both. That is not what the data shows in the United States of America. It shows that the white male is more likely to have timely intervention than the Black male. Now, while we're in the ED, we go over to a corner where we see a couple of patients that came in with a blue foot that's cold and pulseless, no blood flow. And we have some options. Go right to the cath lab or the operating room and do an angiogram, find the blockage and restore blood flow with a balloon or a stent or bypass or endarterectomy, or we can do an amputation. Our question there is, who gets the amputation? And I'm sure your answer is why, of course, they both get the very best care that is available. That is not what's happening in the United States as of 2023. The Black patient will be more likely to have a limb amputated. The white patient will be more likely to have limb salvage surgery. This is not new. In fact, the first papers to show racial disparities in the use of these cardiovascular procedures was in the 1990s. The last one that I've seen was just last year, a couple of months ago. So 4 decades of papers documenting studies that show what I just showed you to be true. So I want to be sure you know this. So this isn't hidden. It's not hidden. In fact, a few years ago, we did a review paper. We tried to gather up all these papers. And what we found, and this was in 2014, is that in a 20-year period of time, there had been 300 papers. You go to PubMed, put in black, white, healthcare disparities, cardiology, bam, 300 papers came up. 300 times it was documented. And the sobering thing that we pointed out in this review article was that things were just as bad at the end of that 20-year period and documenting the problem 300 times as they were at the beginning of that period. So we keep documenting the problem, but nothing gets better. Now, there are those who think, and you can count me in this number, that we won't really move the needle on those racial disparities of care until we move the needle on another problem, and that is the profound lack of diversity in medicine. This is cardiology, but I could put just about any specialty up there. While 51% of adults in the US identify as women, only 13% of cardiologists are women. 17% of Americans identify as Hispanic, yet only 5% of cardiologists are Hispanic. And while 13% of Americans identify as Black or African American, not even 3% of cardiologists are Black or African American. I don't think we're going to move the needle on the disparities until we move the needle here. The last thing I want to share with you before you make your mind up about this quiz question is this. I love this study done by Al-Shabli and colleagues, published in 2018, where they had an a priori hypothesis that the diversity, racial diversity on the research team impacts not only the questions answered, but the impact of the research, which they defined as the number of times the research paper was cited. Now, if you're a researcher, one of the most important things you want is for people to see your work, for that work to be cited. So they analyzed over 9 million papers, and they studied the relationship between research impact, i.e. number of times the research paper was cited, and actual diversity of the research team. And they found of all the different types of diversity, diversity of gender, diversity of discipline, it was racial and ethnic diversity that had the strongest correlation. So put simply, if you want your research to have an impact, take a look at your research team. You want to be sure you have some diversity on your research team. So why do we seek diversity in medicine? Is it because physicians who train in diverse environments are more comfortable treating minority patients? Because underrepresented minority physicians are more likely to serve the underserved? Is it because minority patients are more likely to follow the recommendations of minority physicians? Or maybe it's because diversity will help reduce racial healthcare disparities, or maybe this is the reason that diversity on the research team enhances the impact of research. This is a single best answer type multiple question. University of Vermont, what's the answer to this question? I knew you were good test takers. So they told me the truth. You are good test takers. So it obviously is a trick question. The answer is all of the above. And so now I ask you, hopefully now, you have a strong evidence-supported answer. If you are ever challenged, why do we need diversity in medicine? Why are you talking about enhancing diversity? Why do we need to re-engineer the admissions process, the GME process, the faculty search process? Why? Hopefully now you would be checking strongly agree and agree. But if diversity does all of these things, and it's not a secret that diversity does all of these things, why aren't we there yet? Why aren't we there yet? A couple of reasons, and some of those reasons start with us. And I don't mean the people in this audience and the people on Zoom, because very likely you are the choir. But not everybody believes we should strive to enhance diversity in medicine. So we don't really have a consensus. That's a strong statement. Let me back that up with some data. This is a paper published in the Annals of Thoracic Surgery in 2019. They did a survey. So thoracic surgery is not a very diverse specialty. And I'm not picking on them because my specialty is not a very diverse specialty. And so they have, the Society of Thoracic Surgeons, put together a diversity committee to try to address that problem. One thing they wanted to start with is, what are the attitudes about diversity amongst our ranks in the Society of Thoracic Surgeons? And so they did a survey, and like most surveys of this type, some of the very best, some of the real gold in this paper was the answers to that last question on the survey. Tell me whatever you want to about this topic, okay? So here are some of the responses to that question. White males are currently being discriminated against in admission to college, med school, and residency programs. CT surgery should be a meritocracy. I do not believe barriers exist. This myth of the necessity of diversity and inclusiveness is political correctness on steroids. We need to worry about turning out well-trained residents. The STS doesn't need to address diversity, and frankly, this shouldn't even be on the radar of things to be done. Finally, what barriers? There are no barriers. None of the above are important. Now, it's not fair for me, cardiologist, to pick on the cardiac surgeons. They're our colleagues. I don't want to seem like I'm throwing them under the bus, so I'll do some self-examination. So we did this paper. We did a survey of cardiology fellowship program directors, the gatekeepers, right? You don't get to be a cardiologist unless you get past the cardiology fellowship program director and their selection committee. We wanted to know how this important group feels about diversity. Here's one of the first questions we asked. We said this: diversity is a driver of excellence in healthcare delivery. In other words, the more diversity represented amongst your providers, the better the care delivered. Do you believe this? Fortunately, almost 70% said yes, that's good. 5% said no, I don't believe that. 25% said maybe. So that's 30%. 30% of the program directors aren't sure if diversity enhances the quality of care. In that same paper and on that same survey, we gave them 10 characteristics. We listed 10 characteristics of cardiology fellowship applicants. And we said, rank them according to which of these 10 are in your top 3 when you are making your rank list. When you're making your almighty rank list, which of these are the most important to you? And here are the results. So as you can see, the top vote getter was clinical skills. I don't have a problem with that. I'm sure you don't either. Next was ability to fit in. And I hear some out there, because what does that mean? Ability to fit in. I wonder if it means the same thing for you as it does for me or for someone else. And you can see, I won't read them all to you. You can see them, but let your eyes go all the way down to the bottom. That's where you will find diversity or the ability to enhance the cultural competency of the program. Only 6% said that that is a top consideration when making the rank list. So when I say to you that we don't have a consensus, this is what I'm talking about. Last example. I wonder if many of you have heard of the now infamous the Wang, W-A-N-G paper. Anybody heard of that from Pittsburgh? So it was a single author paper, a position paper, accepted for publication by the Journal of the American Heart Association by a professor at the University of Pittsburgh, talking about diversity in cardiology. Despite the title, it was an anti-diversity piece. And in this piece, he said several things that were very harmful to our trainees and harmful to those who work to enhance diversity. One thing he said was, yes, it might be true that we don't have very many Blacks, Hispanics, and American Indians in cardiology, but that's because they're not qualified. Another gem was, it may be true that Black and Hispanic and American Indian cardiologists are more likely than others to serve underserved communities, but that's because they didn't pass their board exams. And you know, if you don't pass your boards, you know, you don't get to operate at the nice, shiny hospital on the good side of town. You kind of have to go out to some really, really remote rural place. Remember, I've already shown you the data that they come into medical school before they've taken any exam with that in their heart. Well, so a group of us got together and wrote the editors and pointed out some inconsistencies some misstatements and some outright falsehoods based on data. And they did retract the paper, but I want to poll you real quick on this. I learned something about retracted papers. I used to think that when a paper was retracted, it was gone. It was erased from the universe. It isn't. You could still look this up on PubMed, and you can still go to the archives of the Journal of the American Heart Association, and you can still see this paper, but it has the words retracted written lightly across each page as you read it. So it's still there. Did you know that? I thought they were just blasted into smithereens, but no, they're still available. Well, so we wrote a rebuttal, and it took them a year to publish it. But interestingly, the editors didn't want us in the rebuttal to make any mention of this paper. So when we started out in the first paragraph, we wanted to rebut the one. Nope, just take out any, don't reference it at all. So now it's just a standalone paper advocating diversity in cardiology. But as I started, I'll say again, not everybody believes we should strive to enhance diversity in medicine. There may be some people listening on Zoom, maybe some people here in this room who are not part of the group of people who believe that we should strive to enhance diversity in medicine. So that's part of the reason of why we are not there yet. So what can we do? Now, if I've made the mood kind of somber, I apologize for that. I'm going to spend the rest of the time trying to get us up back into a good mood because we want to celebrate Dr. King and we want to celebrate the beauty of diversity. So what can we do? So we need to recruit from deep in a supply chain. And I'm talking about going all the way back to elementary school. We need to recruit from the immediate supply chain. These are people right around the corner, pre-med students and the residents. Bias is a big problem in our selection processes. We need to identify it, talk about it, and mitigate that bias. We need to elevate diversity competency. What if you took diversity competency and instead of it being number 10 out of 10 things that you consider, what if we elevated that up to maybe a top 3 consideration? And then we need to set an example and be an activist against those structural and societal things where bias and racism impairs progress of our students towards becoming a physician. So what can we do? Recruit deep in a supply chain. And I'm going to bet that this next slide I show you is going to be the cutest slide you've seen all day. How about this? This is the white coat ceremony of these kindergartners in the K-12 Health Sciences Academy, which is a joint program between the Ohio State University Medical Center and Columbus City Schools. These children will have health sciences introduced into their curriculum. And 3 times a year, they will actually meet and interact with medical students, dental students, pharmacy students, nursing students, and attending physicians. Imagine that by the time they get to be seniors in high school, the idea of being a doctor to them is going to seem like, that's no big deal. I've been around doctors all my life. Now, you don't necessarily have to do a grand gesture like this, but please reach out to these early students because this is real supply chain work. You got to recruit from the immediate supply chain as well. This is simultaneous work. Do all of this together. Of all of the projects that we're doing at ACC, the one that I'm most proud of as the chair of ACC's diversity committee is our internal medicine resident mentoring program. So we reach out to internal medicine residents who are in the groups that are the least represented in cardiology: Blacks, women, Hispanics, and members who identify as LGBTQ+. And we invite them to join us where they will get an ACC attending cardiology mentor that will meet with them quarterly for a 30-minute meeting virtually. And twice a year, they will hear from cardiology fellowship program directors on how to be more competitive. There's no guarantee that you get into a cardiology fellowship if you're in this program, but our goal is to mentor you to be the most competitive cardiology fellowship applicant that you can be. And by the way, we put all of them on a plane and fly them to the National ACC meeting. This is now one of my favorite selfies. This is me At ACC 2022, behind me, you see 300 women, Hispanic, and Black internal medicine residents who are aspiring cardiologists. It is really a very exciting program. So we just went through the match, and many of them matched, some of them didn't, but even those who didn't appreciated the fact that in this program, they had access to information that very often our underrepresented residents do not have. Identify and mitigate bias in medicine and in the selection processes. You heard Dr. Amidi talk to you about this study. We had our large 140-member admissions committee at the Ohio State University College of Medicine take several implicit association tests and found out that unconscious bias against Blacks, against women, and against members of the LGBTQ+ community was present in 50% or more of the members of our admissions committee. They're good people. I work with them every day. It just shows you how you can consciously feel one way about these things. You can be very egalitarian minded, but your unconscious mind might have certain associations that might impact how well you do. That is what some people have called the negative side of this research project. But let me tell you about the positive side. After we got those results and had at our annual admissions committee retreat, a discussion about those results and a workshop where we workshopped strategies to help us override our unconscious biases. The very next class we admitted was the most diverse class in the history of the Ohio State University College of Medicine. So we immediately made implicit bias mitigation training a requirement for being on the admissions committee. We started this thing called bias and equity teaching rounds, where we dedicate a grand rounds to discussing instances of bias and racism that occurred on the wards. We de-identify. We don't want, it's not to punish anybody, but it is to discuss these instances, learn from them, and use evidence to make sure they don't happen again. So what are some examples of some of the things we discuss? One thing we discuss, an example might be a time when I was making rounds at an academic medical center, and we went in to see a Black person who was there with new onset heart failure, and we came out and one of the residents said, "Oh, by the way, Dr. Capers, I forgot to tell you, his drug test is negative." And I said, "Why do we do the urine drug screen?" And he fumbled around with his words, and then he threw his colleagues under the bus. He said, "Well, it was the night team that ordered it. It wasn't me. It was the night team." I said, "Well, that's okay. Let's go to the computer. Let's look at the H&P from the night team. Let's see if they saw something that made them think that they should get a urine drug screen." And we looked and we looked and we looked and we didn't see it. And then I reminded them that just last week we'd admitted 2 white patients with new onset heart failure, and nobody ordered urine drug screens on them. That is an example of an incident that we would discuss at these bias and equity teaching rounds, and using audience response systems, poll the audience, and then have some evidence-based discussions about how we move forward and make sure this doesn't happen again. Identify the bias, mitigate the bias. Elevate diversity competency to a top consideration. In this perspective piece that we called Black Lives Matter in the Cath Lab 2, we shared a process we had at the Ohio State University for choosing interventional cardiology fellows. In our application screening and review process, it was a point score system. 5 things we wanted to see in our fellows, and they were each scored equally, and that was clinical skills, collegiality, academic curiosity, leadership potential, and diversity competency, or the ability to be an advocate for health equity in interventional cardiology. If there's someone here who's thinking about applying to interventional cardiology at Ohio State, let me tell you, this is how you are going to be rated. Now, when you use a system like this, what is the outcome? The outcome is that for 8 years in a row, at least one of our 3 interventional cardiology fellows was from an underrepresented in medicine group. When you truly believe that diversity enhances quality, then you put into place tools that will help you to select diverse candidates. Now, all the candidates don't have to be Black or Hispanic. You know, being an advocate for health equity in interventional cardiology, I have to tell you, doesn't have much to do with race. You can be white with blue eyes and blonde hair, but someone who has done health equity work, someone who has treated patients in a group other than your own, and you would get a high score on diversity competency. So recruit from the deep pipeline, the immediate pipeline, mitigate bias, elevate diversity competency. And number 5, be an activist. We're talking about Dr. King, so let's all be activists. And these social determinants of health that we all know and talk about so well are also social determinants of academic success. So imagine being a kid that wants to be a doctor, and every 3 years your family moves. And hunger is your constant companion. And the schools you attend are underfunded and overcrowded, and your family transportation is unreliable, so you can't go to that after-school program on math and science. Think about being a child growing up like that, and they face 20 years, 2 decades of obstacles to becoming a doctor. And then after all that, you get up to medical school admissions, and then the admissions committee, half of them have an unconscious bias against you. It is a wonder that we have any doctors of color, but we do. But we have to speak out, whether that is kneeling to protest against police brutality, marching to reduce the price of insulin, using revolutionary art to make a point, or like these students at University of Texas Southwestern, registering voters. Isn't that a wonderful thing for a medical center to do? Social determinants of health, we might feel helpless, like we can't do anything about it, but what you can do is get people registered to vote. And so for these medical students to do that is a true form of activism. So in conclusion, I want to say that there is, as you know, strong evidence that supports the contention that enhancing diversity is going to improve healthcare and biomedical research. We're not there yet, but we can get there, but we need a sense of urgency. Strategic initiatives can help us be successful. So let's practice evidence-based medicine. I'm a cardiologist. When a pharmaceutical sales rep comes to me and says, Dr. Capers, don't use this drug blood thinner anymore because this one is better. The first thing I say is, show me the data, show me the evidence. And we're all proud to say we practice evidence-based medicine. Well, the evidence shows that diversity saves lives. So let's be about it then. And we can do that. I like, I'm going to end with this picture. One of my favorite men, one of my favorite quotes. I was glad to hear it earlier today. And this is one of my favorite pictures of him. I said this on Twitter a few days ago. Most pictures of him, he's looking really pensive, maybe posing in front of library books. You rarely see him look like he's a little annoyed or angry, but I think here that he is. And I like to imagine he's angry because we can't wait. We can't wait any longer. Diversity in medicine is a life-saving mandate. And Dr. King is pointing at you, and he's pointing at me because he knows that we have the power to do something about it. Thank you very much. Be happy to take any questions or comments.
Thank you so much, Dr. Capers.
Thank you.
For a wonderful, thought-provoking, and data-driven talk. We're happy to take questions either from the audience here, and if you're on Zoom, please put them in the Q&A tab, and we'll take as many as we can. And we have microphones coming around here.
Hi,
Hi.
my name is Deborah Kamimukaz. I work with Mary. I'm a postdoc. And so the conversation, I'm on Twitter, so we hear a lot about the conversation when it comes to diversity in medicine and in research. I'm also part of in cardio. Something that has been happening, where we are pushing the conversation is about the pipeline. We understand that we are bringing in scientists, we are bringing in doctors into these fields, but how do you keep them there? Because we feel as though we get there, but for some of us, we don't have the resources or we deal with all these different issues. So do you have any thoughts about it or any insights?
Well, thank you for your question. And if I understand your question, you're saying that once we get people from diverse backgrounds in the door,
Yes.
How do we keep them
Yes,
and make sure they're supported?
yes,
It's such an important question, and that is we have to pay it. Usually you say these two words together. Diversity and inclusion, and the inclusion is just as important as the diversity. And so we must make sure that we are prepared as we embark on these strategies to enhance diversity, that we are prepared to bring in people who might be different from a different culture and to support them. So working on a climate of inclusion is just as important as working on diversity, because if you don't, you'll have a rotating door. They'll come in, they'll get their degree, and then they'll go out and never come back. I'm an alumnus of the Ohio State University College of Medicine. And some years later, I wound up on the faculty there. And every year we have a medical school alumni reunion. Usually have it the same weekend as a big football game. We get everybody to come back. And I knew that we had graduated lots of Black and Hispanic students, but you never saw them at alumni weekend. And so I reached out to some of my classmates, and some of them said, I'm never coming back because of how I was treated when I was there. And so just getting them in is not enough. You have to make sure you have a welcoming climate so that they really feel valued. And it's important for teams that are working on this to be sure we're working on both simultaneously. So as you're working to recruit, then you need to be having maybe some town hall discussions about the value of diversity, how it makes our research better, how it makes our clinical care better before these new people arrive. And it is constant work. Yes.
Hi, I'm Liz Bonney. I'm the head of reproductive sciences and OBGYN. Just a comment, okay? I have seen so many situations where that 5% who don't believe in diversity are actually quite toxic and actually attack and do something traumatic to people of color in the medical environment. And something needs to be done to provide fail-safes against that kind of behavior. So for example, medical residents in medical subspecialties are maybe 3% African-American, but they represent 20% of the people who are dismissed from residency programs. And we have had people who were dismissed, our only resident of color in many years was fired. And it was because of toxic people in the environment. So is there a panel? Is there any plan to have a way of fail-safing and checking on programs to make sure they're not making these decisions to fire residents when they shouldn't? Is there any way to fail-safe in general to make sure medical students aren't dismissed out of medical school when they shouldn't be? What is the fail-safe against those 5% toxic people who are traumatizing people in the pipeline? It's not going to be just a matter of, let's do a class and let's elevate inclusion. We have to have something more firm and structural to be able to take care of that. And thanks.
Yeah, thank you. Thank you for that question. And you're absolutely right. This is a problem that we have to take very seriously. It all comes down to senior leadership. So we need senior leadership. How we get there is, I don't have an easy answer for, but we need senior leadership to take this problem very seriously. And in academic medicine, we have rewards, and we have punishments, we have carrots, and we have sticks. And so we need senior leadership to put in place a system of rewards and punishments for those who oversee our trainees, for getting diverse individuals through successfully, not just getting them in the door, but getting them through successfully, and really doing an important analysis when somebody isn't getting through successfully. We can lean very heavily on our accrediting bodies because they really do some good work for us, the ACGME, for instance. But often they kind of come in too late, right? So when you have an ACGME visit where the residents gets to go behind a closed door and say, this is what I think about the environment here. And ACGME can put your program on probation, but that might be too late to save that one individual that was already dismissed. So we've got to lean on our senior leaders, build alliances with faculty who care. And those faculty aren't just faculty of color who care that trainees are treated well, and also look for some leadership from our accrediting bodies. Because there's one thing that gets medical centers changing their behavior is JCO and LCME and ACGME. And all of those, all three of those places will actually sanction people who are letting racism impact the success of people, but we've got to figure out how to do it on a more preventive medicine kind of basis rather than after the fact. So big problem. I'm not sure I've got an easy answer for that other than we need strong senior leadership.
Yes, we do. Okay, so. It's because of my mask. Okay. All right. Can you hear me?
Yes.
Okay, fantastic. A question we have is, what do you think are some of the larger challenges to increase diversity in healthcare fields? And do you think the cost of graduate education, graduate medical education is a contributing factor?
So let me take those one at a time. So give me the first half first.
Yep. What do you think are some of the larger challenges to increase diversity in healthcare fields?
Some of the things that we went over. So there is a major portion that is going all the way back to the lower grades in school. So that bias that we talk about in medical school admissions, it's all along the pipeline. So because they're gatekeepers at so many places, right? So the gatekeeper, the third grade teacher who decides which students will be referred to the gifted and talented programs and which ones will not, that person is a gatekeeper. And if in their mind, children of color are naughty and not put in the gifted and talented program, they've just robbed us of a few doctors. In high school, the high school counselors who decide who gets the information about the summer program. When I'm sure it's all done electronically now, but when I was in high school, if NASA or the American Cancer Society had a wonderful summer program and they wanted high school students, they would communicate directly with the high school counselor, and that high school counselor would give that information to the students that they felt like were worthy of that information. And so if they have a bias against children of color, then they don't get that. So some of the problem is way back in the deep supply chain. And then some of the other ones we laid out just as they are. What's now the second half of the question there?
Do you think the cost of graduate education is also a contributing factor?
I do. Yes, absolutely. We have students now graduating with, $400,000, $500,000 worth of debt. That's just medical school. And if they borrowed money in undergraduate, that's even worse. And so some of this is cultural, right? So if you come from a family and your family understands finances and understands that you'll be able to pay something back, and the word loan is not a dirty word, then when you're applying for medical school and you see, I'm gonna have to borrow $100,000 a year, you're more likely to say, oh, okay, I'll be able to pay it back. But some cultures, the word loan is a dirty word. And when you see that, you just think, you know what, maybe I'll get my degree in engineering instead because it's a long haul to become a doctor. So it clearly is. I was really pleased when NYU Langone went tuition free. And then I think a few others were. I was really hoping we were going to see like an arms race of medical schools saying, well, we'll waive our tuition. Well, we'll waive our tuition. But we didn't quite see an arms race. But I think there's no doubt that has a disparate impact on people coming from socioeconomically deprived households.
Yeah. Thank you. I'm Roxana, and I love your presentation.
Thank
this
you.
is a comment. I would like to add that physicians and researchers must to be advocating at a government level to change its policies and laws to make all this happen. Because if you physicians stay in the university level without changing the policies, without changing laws, it will not progress.
Thank you very much. Thank you very much. We absolutely need some legislative help from our politicians.
Hi, Mary Cushman.
Hi.
And welcome to Vermont. It's great to see you. So many of the people I would imagine on Zoom, I don't know who's there, but I imagine many of the people are sort of rank and file faculty members. Maybe they're not a division director or department chair or program director or on the admissions committee or anything like that. And if you could pick, one thing that the average faculty member at a medical school could do to help this situation that we're discussing, is there something particular that jumps out at you?
Yes, go to and participate in a career day at a local high school or elementary school. Be visible, go out and be visible. Race doesn't matter. I grew up in Dayton, Ohio, on the west side of town. If you know your Dayton geography, that's the black side of town and a predominantly black school. And we had career day every year, and I'd get so excited when I saw the sign, health and medicine, and I'd go running in there, and it would be, well, nobody could make it today. So, but next door we have business, and next door for that we have education. It would not have mattered to me the race of the doctor, the gender of the doctor. If that would have been a doctor there saying, oh, you want to be a doctor? Well, guess what? I think you're going to be a good one. And let me tell you about the wonders of being a doctor. So something that we can all do, reach out, elementary school, high school. I can almost guarantee you that if you as a physician call up a high school and say, I'm interested to come and talk to some of your students about what I do, they will delightedly find a place for you.
Yep, we have another one here. Okay, so in the example of the Black African-American patient being more likely to receive an amputation compared to their white counterpart, is that due to pure racism, or is it unequal treatment related to racist assumptions of a Black patient's inability to pay for the other type of treatment?
Well, so it's a fantastic question. So what we know is that when they have the white and the Black patient with critical lower extremity insufficiency, when they have the same degree and same extent of disease, these are what the national statistics show us. When I lectured to this about medical students, I asked the medical students to help me construct a list of potential causes. And racism is one of the things that's on the list, but it's not the only thing that's on the list. Finances, health literacy, patient mistrust of the healthcare system are all things that are on the list. So it's a multifactorial problem. And I'd say that, yes, the two things that the questioner mentioned are both on the list.
I have a question.
Yes.
You've been a dean of admissions. So I wonder what your thoughts are on de-identifying applications for race, ethnicity, gender coming through the application process as an effort to diversify.
So that's a great question. I can tell you it's a two-sided coin. And just like most things have both a positive side and a negative side. We know that biases unconsciously can be triggered by the sound of names. If a name sounds ethnic or international, it can be triggered by appearances, how somebody looks. It can be triggered by looking at that line where they self-identify their race. And so there is some value in de-identification to some extent. So what we did at Ohio State, we took away the photos. There was a time that we used to, when I became the dean of admissions, we used to ask our interviewees, bring a photo of yourself. So they would bring a photo and then we'd attach it to their file. And then when we're in the room discussing them, we had the file, and so we were looking at their photo. It became obvious that that was driving some biases. So we took away the photo. And we thought for one while about taking away the names, but others have asked us that. They said, well, why not redact race from the application? Because what I thought we'd rather do is to train in how to override our unconscious negative biases. But if you're trying to build up your diversity, you kind of need to see that. Another way I would put it is, if you're the program director of a surgery residency program that has never had women, and now your chair says, we look so backwards, this is wrong, we clearly get strong women candidates, I want some women in my program. Well, if you redact gender, you're not going to be very successful at that. So looking at it as a way of recruiting, I think is the right way to use it.
There is another one here too. Okay, this question is, what can we do as individuals to address the privilege and bias that entitles people to mistreat others based on cultural, ethnic, gender, or other so-called differences?
That's a great question. I wish I had an easy answer for that, but one of the strongest things we can all do to help deprogram our mind and get rid of the biases that we all have, by the way. Everybody has implicit biases, and there is a natural human instinct of us versus them. But we can override that consciously, and one of the best ways to do that is simply forcing yourself to spend time with people who are not like you. So the next time you go to lunch, next time you have a lab project, instead of going with your crew, with your posse, invite somebody else. If you're, this usually gets a chuckle. If you're a Democrat, have lunch with a Republican. If you're a Republican, have lunch with a Democrat. Because when you force yourself to be around people who are not like you, inevitably you see some positive characteristics and some positive traits. And then your mind starts to say, oh, not all people in this group are negative. And that actually reduces some of your unconscious negative bias. So put yourself in diverse situations. If you are not Jewish, but the Jewish students or faculty are having a Jewish celebration, go. If you are Jewish, go see what the Black students are doing. If you're a woman, go see what are the men talking about, and vice versa. If you identify as one end of the binary gender identity spectrum, go spend some time with people who are on the other end of that spectrum. Just exposure to people who are not like you.
Dr. Doherty, there's one last comment here that I actually would like to read. Just a comment, as a current medical school applicant, even the application process can be
Oh, we got some
financial.
pre-med students on the line?
Oh, heck yeah.
All right, yes.
As a current medical school applicant, even the application process can be financially taxing. Applying itself is becoming inaccessible from the cost of the MCAT prep courses, additional ethics exams, primary applications, secondary applications, etc. Depending on the SES or the socioeconomic status, this is a strong deterrent for many applicants.
Yes, thank you. Thank you. So, well, first of all, thank you for applying, and thank you for your perseverance. Hope we get to shake your hand one day as a doctor. This is a big problem, and thank you for reminding us all and pointing it out. The Double AMC tries. I mean, as those who work at admissions know, they have a fee waiver, which can waive the MCAT fee, some portion of it, waive some of the application fee, and then medical schools tend to waive their secondary application fee if you got the AMCAS waiver. But to get that, if memory serves me right, you have to be within 300% of the federally designated poverty level. And so there are a lot of people who are slightly outside of that, but still are having a tough time paying for these things. So I don't have an easy answer there. We can look at things we can do to make it less expensive, more scholarships, more grants, and not just scholarships to pay tuition, but scholarships to take the MCAT or to take an MCAT prep course, things like that. And that may take private donors and us maybe lobbying all the people that we know. So hang in there. We know it's expensive. We're rooting for you.
Thank you so much for a really enjoyable talk, a discussion, lots to think about, lots to chew on. I want to take an opportunity to also thank Tiffany Delaney, our Director of the Office of Diversity, Equity, Emily Marino, and Krista Kohler, who are great staff people. Also, thank you, of course, to the Dean's Office for sponsoring this. And we look forward to more communication with you. Thanks so much.
Thank you very much. Yep.